Hi guys, Dr. Rajarathna here. Today being the World Glaucoma Day, March 12th, I thought I will talk to you a little bit about something on glaucoma. So I thought NTG we'll talk about because normal tension glaucoma NTG is something that is underdiagnosed, I would say, because people do not have the awareness, and even students, you do not have much knowledge about it, because all that we think is glaucoma is all about intraocular pressure. When the intraocular pressure is more than 21, boom, everybody is scared. And when then IOP is less than 22, that is 21 or less, we think everything is fine. No, it's not fine. You could have NTG because even young people have normal tension glaucoma. So I will discuss 5 points. Okay, so what are these 5 points? So first thing is, in normal tension glaucoma, the IOP is lesser than 22, that is 21 millimeter mercury or lesser. Is that clear? But they have the characteristic findings of glaucoma. What are the criteria of glaucoma? Number one, characteristic optic disc changes and visual field defects. Yes, so that is point number one. Now what is point number two? So point number two, let's talk about this optic disc change. Now, is there any optic disc change that is characteristic of NTG? No, nothing. It all overlaps with POAG, primary open angle glaucoma. But yes, we do have these disc hemorrhages that occur quite commonly in NTG, along with other optic disc changes, of course, but they mean progression of NTG. So if you see disc hemorrhages in a patient with glaucomatous optic disc changes, it means that this NTG is progressing to become a primary open angle glaucoma. So what is the frequency of progression? In how many people do we see this progression? So if you monitor these patients over a period of 5 years, 50% of them can progress to POAG. So that means we need to treat these patients. Okay. So now we'll go to point number three. So point number three is about visual field defects. Is there again any particular visual field defect which is characteristic of NTG? Yes, we do have very dense and deep scotomas around the fixation. So basically what is called as paracentral scotoma, ma'am. But paracentral scotoma we see also in POAG, earliest field defect, yes. But you do not get them as deep as in NTG. And also in NTG, the intraocular pressure is less. And still you get dense and deep paracentral scotomas, especially in young people. Okay, so that is something you need to know about visual field defects of NTG. So that is point number three. Now point number four, how do you treat them? Of course, any case of glaucoma, the only option is to change or lay our hands on the modifiable risk factor, or in fact the only modifiable risk factor, IOP. So we have to reduce the IOP. So how much would you reduce? We would use a drug or a combination of drugs and bring it down by 30% from the baseline. So even if my pressure is 20 millimeter mercury, so from 30% of 20, you know, my maths is not that good, so you calculate. So 30% of 20, you will bring it down. By that factor, you will bring it down. That would be your target. Now, what drug? So brimonidine is considered to be the best drug over and above even beta blockers and over and above even your prostaglandin analogs, especially for NTG. Now, why brimonidine? You all know brimonidine is a neuroprotectant. It prevents my retinal ganglion cells from dying. Yes, so that also plays a role. So brimonidine is a better drug over everything else when it comes to NTG, all right, for normal tension or low tension glaucoma as we call it. Now, anything else in the treatment? Yes, many of them do have hypertension as a risk factor. So if patients are hypertensives and are on antihypertensive medication, they should never take these medications at bedtime, preferably to take it late evening rather than at bedtime. Why? Because nocturnal hypotension is one of the risk factors for NTG. Why? Because the decreased blood flow to the optic nerve is considered to be a risk factor in the pathogenesis of NTG. There we go. Fifth point. So that means finally we'll come to the pathogenesis. So there is a lot. Okay, so it's multifactorial. So they say there is a genetic vulnerability because the optineurin gene or the OPA1 gene has some association. Migraine has some association, autoimmune mechanisms, vascular factors, inflammatory. So all these, and basically a weak or a little thin sclera which is not able to bear the brunt of even a normal intraocular pressure. So you remember the lamina cribrosa, which is a part of the sclera through which the axons of the optic nerve leave the eye. So this lamina cribrosa is kind of a little weak. So the scleral weakness is not able to bear even the normal pressure, that is less than 21 millimeter. So there is a posterior bowing or a bending backward of the lamina cribrosa. Ma'am, how is that going to cause glaucoma? So there's going to be a stretching of my axons. So this stretch puts on kind of a it leads to damage of the axons, and after all, what is glaucoma? Death of ganglion cells and their axons. So somehow it is related. So it's a multi-factor. So these are my 5 cents, not 2 cents, 5 cents or 5 points about NTG on the occasion of World Glaucoma Day. So anyone in your family, if they are older, especially older people, even if the intraocular pressure is less, they might have NTG. So better to get the fundus examination done, at least get one fundus photo documented. Yes, get a printout of the fundus photo, yes, the optic disc photograph, so that later when they see another ophthalmologist or the same ophthalmologist years later, there's always a baseline to compare. Okay, so it's not just about IOP. So it is about looking at the optic disc. So that means a retina checkup is a must, and also visual field measurements if needed. All right. Okay. Thank you guys.